Very good afternoon. At the outset, I would like to thank Aditya for giving me this opportunity. Already, Dr. Vishal has given an overview, the intravitreal injection, the commonly used injections, and I'm going to speak on the surgical management of acute post-op endophthalmitis. So I will be showing few cases. First case was an acute post-operative endophthalmitis. As you can see in this case, there's a hypopyon, and this had an complicated surgery. Uh, it was operated for cataract, but the lens was not there. So there was a dropped lens as well. So first of all, we clean the anterior chamber. The hypopyon is clean. A day before, we had given the intravitreal as well. Now you can see dense exudates all over the retina, and the dropped IOL also we can see. What we need to do is a thorough vitrectomy, and we need to take out all the traction around the intraocular lens. Otherwise, while retrieving the IOL from the vitreous cavity, we might induce a retinal break. So once we have freed this IOL from all the exudates and the membranes, we take out the lens. Luckily, the cornea was better, so we could see what is there inside. And after retrieving, you can see the one haptic is already broken, so we retrieve the other part as well. And then the globe is closed, the main wound is closed, and we need a closed chamber to do our proper vitrectomy. Now we are left with a lot of exudates on the retina, as Dr. Vishal was mentioning, that nowadays with a better visibility, better viewing system, we can actually dissect quite a lot, and the target of the surgery is to clear as much as possible the exudates. Here I'm trying to do a base dissection as well. Obviously, we need to be judicious in leaving, like sometimes the membranes are very adherent to the retina. It is not advisable to pull the entire membrane. When you see, it is not it is very sticky, and we might create an iatrogenic break, because creating a detachment in this kind of cases, the prognosis comes down. So as much as possible, we need to trim the base. And you can see the retina. We can now see the retina. It was entirely covered with the exudates, and then come out and give intravitreal injection. This patient did pretty well, and later on we had given a secondary IOL. This is after the surgery we are giving the intravitreal injection. Now, second case, this is an acute onset, but it had a very delayed presentation. You can see almost there's a seclusion pupilly. So in this cases, we have to we have to take out the IOL. Otherwise, we cannot proceed at all. So this is how we are actually taking out the IOL first. Once we have taken out, you see the entire globe is full of thick exudates. This patient didn't come in time, although it was an acute, but it was a delayed presentation. Now we are removing this thick exudates as much as possible. And the visibility was quite clear, so we were dissecting the membrane over the retina as well. The target is to remove as much as exudate possible, so that our intravitreal antibiotics work. So eventually the patient did pretty well. This is a the last case is a chronic endophthalmitis. I had already operated once, but it was like every time the exudates were coming and the patient was having symptoms. So this time what I planned is I will remove the IOL because the bag was dirty. In spite of repeated intravitreal injection also, we could not get rid of the infection. So this is like in a chronic endophthalmitis, sometimes we need to take out the IOL along with the bag. So this was the plan. You can see on the retina there is the exudate lying, trying to shave off the vitreous base as well as much as possible. Sometimes with a soft tip cannula we can actually take out um, uh, the balls of exudates which is lying on the retina. But we have to be very judicious and we should not touch the retina, otherwise we will create a retinal detachment. So once we are through with this vitrectomy, or rather the revitrectomy, because we have already done in a primary vitrectomy, now we need to take out the lens. You can see the lens is the bag is dirty, so we have to remove it, and most likely this was responsible for this chronic endophthalmitis. The section was not that great. There was some iris prolapse, but somehow managed to take out the IOL and put a suture. And once we remove the IOL, we need to take out the bag complex because we know this is at fault. So if we clean up this area, we are going to save this eye. And eventually, actually, this patient did pretty well. So that's the end of the surgery, and then we give the intravitreal injection. Taking out the remnants of the bag. Now you see when we remove the bag complex, the visibility is much better. So the take home is early diagnosis and treatment with antimicrobial therapy are critical. Usually, the diagnosis must be made under critical conditions. Treat with empirical therapy, usually vancomycin and ceftazidime. And obviously, as Vishal has mentioned in the EVA study, perception of the light was the indication of doing a surgery. But nowadays, we do it a much early and with a better prognosis. And whenever we give intravitreal, we see the response, and if it is not responding, we take a call of surgical management in the earliest. Thank you.